for, well, it's important for all of us, but anybody who's going to be involved with COVID to any extent. And it's a session about how to investigate and manage an outbreak. The eagle-eyed among you will have realised this was supposed to be surveillance, but Neil and I have swapped around, and he'll be doing his surveillance session next Tuesday, so you've got this a week early instead. Excuse me. As always, there'll be time at the end for any questions, and if you do have any questions as I go along, please type them into the chat section, and Jo will be keeping an eye out for those. So the aims and objectives, I'm going to have a bit of an understanding about how outbreaks are detected and managed, be able to understand how COVID-19 outbreaks and incidents are managed, and to be able to contribute to an incident management team meeting. And as always, this is an awful lot to get through in an hour, so we'll do our best. And the topics that we're going to look at about the stages of managing an outbreak. We're going to look at the challenges in the various settings that we might see outbreaks in, and different settings have different challenges. And I'm going to work through two examples of outbreaks. One is COVID, and it's a bit of an amalgamation of several different COVID outbreaks that we've had. And one is non-COVID. I deliberately wanted to give you something that wasn't COVID, and it's quite a different outbreak. So those are things that we're going to be looking at. So I guess before we start, what is an outbreak? So either type away in the chat or shout out, what's an outbreak?
It's two or more cases linked by a place or time, something like that.
Yeah, brilliant. So there are three definitions of an outbreak, and that is one of them. So it's two or more people with the same disease or symptoms, and they're linked in time, place and person. So brilliant.
Yeah, on the chat, very similar as well, Valerie. So we've got Amajit and Sarah both saying two or more cases in a setting.
Brilliant. Yeah. So yeah, two or more cases in the same setting is one definition, but there are also another couple as well. An outbreak, you can have an outbreak when you've got a greater than expected rate of infection compared with normal. And we've picked that up a fair bit with things like measles. So measles in the UK, we always have a small number of cases. We have really good surveillance data on measles. If we were to suddenly see an increase in the expected rates of infection of measles, then that would be classified as an outbreak. So we can pick outbreaks up through surveillance data. And an outbreak, it can also be a single case of a very rare disease. So if we were to get a case of Ebola in Sandwell and West Birmingham hospitals this afternoon, that would be declared as an outbreak, and there would be an IMT very quickly organised to deal with that. The same with rabies. So some diseases are so serious and their consequences are so catastrophic that just one case of these rare diseases we would call an outbreak. But really for kind of general purposes, it's two or more people linked in time, place or person, or a greater than expected rate of infection. And kind of while we're on the topic of what an outbreak is, it's useful to just have a quick reminder of what an epidemic and a pandemic is. So an epidemic just means an infectious disease has spread rapidly to very many people. We all know a lot about pandemics. We're all living through one at the moment. And a pandemic just means it's affected the entire globe. It's usually worldwide, but it's affected every region on the planet. Some pandemics are far more severe than others, but it just means it's worldwide. And of course, as we all know, it affects a great number of people, has a higher number of deaths than epidemics, and it can cause great social disruption, economic loss, and general hardship. And we're all living through it, so we can all testify to that. But it's just some useful terms about what is an outbreak, what is an epidemic, and what is a pandemic. So we now need to know how to control an outbreak. And there are 4 stages in controlling an outbreak. And if you do the 4, you're going to probably do a fairly good job. And I'm going to go through these in a little bit more detail now, but they are early detection, rapid structured investigation, control measures, and evaluation and lessons learned. And what I'll do is I'll go through each of the 4 in a little bit more detail, and then we'll do the kind of 2 real life examples to see how that fits in with this framework. So the first step about controlling an outbreak is detecting it. And that is absolutely crucial. It sounds quite obvious, but the sooner we know about an outbreak, the sooner we can put a stop to it. If we never find out about an outbreak, we can't do anything about it. We need to know about it very quickly and very early. And there are lots of different ways that could happen. So really, we can find out about outbreaks either formally or informally. So formal reports, Neil is going to do a session next week about surveillance data, but we have a great deal of infectious disease surveillance in the UK, in Europe, globally, and we can pick up outbreaks through that surveillance data. We also have a system in the UK of notification of infectious diseases where doctors and labs are legally obliged to report cases of certain diseases. And I showed you that list in the very first intro session. So any doctor diagnosing a case of measles or a case of COVID-19 or a case of Salmonella typhi is obliged to notify that case to the proper officer. So by these ways, we can pick up if we're seeing an increase in cases and we can take action about it. We get data directly from the labs. So laboratories will directly report to Public Health England about how many positive samples that they've identified. So if labs are suddenly seeing an increase in E. coli, for example, that might lead to questions about what's going on. Do we have an outbreak? But we can also get early detection of outbreaks through less formal, so more informal routes. So members of the public, people can phone up. So people often phone up environmental health officers and say, I went to the restaurant on the corner yesterday and now I'm really ill. And sometimes that's not particularly reliable, but sometimes that can be the beginning of an outbreak. We can use social media, and I think there's been some quite interesting studies looking at the way outbreaks can be detected through an increase in search terms. So if lots of people in the city are searching flu remedies, for example, that might be a very early indicator that flu season has started early. But people can email, Twitter, what's going on Twitter. And of course, we've got our Public Health COVID inquiries inbox. And at the moment, we're getting an awful lot of inquiries and notifications through that inbox of potential outbreaks. So that's a very important notification route. And it's important to say that the early detection is not the full story. This will never be the full story. What we know about this case is there might be a problem. It might not be a problem, it might be nothing, or it might be the beginning of an absolutely massive outbreak, and we don't know at this stage. But we have got the early detection that there might be a problem, and we now need to find out an awful lot more about it. So the next stage in how to control an outbreak is rapid structured investigation. So we've got an indication that there might be a problem. We don't know that there is or not, but we are concerned and we want to find out a lot more. And really, the words rapid and the word structured are absolutely crucial. Time is of the essence here. We're talking about infectious diseases that can be fatal. If they're not fatal, they can lead to, significant ill effects leading to hospitalization or long-term health problems. So there is absolutely no time to be hanging around in outbreak management. It is quick. So time is of the essence. at the very least, we want some descriptive epidemiology. We want to know about the time, we want to know about the place, we want to know about the person. And I'm going to talk about that in a little bit more detail next. But we want to have a kind of early description of our outbreak. So, for example, it might be 6 staff out of 20 who work at a burger takeaway joint have got symptoms of COVID-19. That is one way of describing what's going on. We might want to do some more analytical epidemiology. Now, that's quite unusual. Normally, it's very descriptive. We talk about the time, the place, the person. But sometimes we actually might want to do some case control or cohort studies looking in more detail. So, for example, if you had a wedding and everybody who attended the wedding, or a lot of people who attended the wedding, became unwell, you might want to do a cohort study looking at what people ate and odds ratios and things. But at the very least, we want that descriptive epi of what's the time, what's the place, what's the person. The timing is crucial. When did our outbreak start? Is it still going on? Has it finished yet? We need to understand the timing of the outbreak. We won't know what the causative organism is at this point. We're dealing with insufficient information. We're always dealing with insufficient information in an outbreak. But we'll have a bit of an idea. Is it a respiratory infection? Is it a diarrhea infection? You know, we'll have a little bit of an idea about what might be going on here. We can form a hypothesis. So we can take a bit of a stab at incubation periods and periods of infectivity. We want to be finding cases at this point. We might want to be trawling medical records. We might want to be using the media. If you ate at the wedding breakfast on Smethwick High Street on Friday, please let us know. Some people are ill. We might want to be using the media. And there is a real rush here. There may be people who've been exposed who are not yet ill, and so there's a window of opportunity to take action. So we really have to get a wiggle on. And one of the useful tools in our armoury when looking at the sort of spatial timing of outbreaks are epidemic curves. And epidemic curves, if you hadn't heard of epidemic curves at the beginning of the year, you certainly have now, because they're all over the press and all over the media. But they're an incredibly useful tool to describe an outbreak. And we can tell an awful lot about what's going on just by looking at the epidemic curve. So this is an epi curve. And what you have with an epidemic curve is always on the x-axis, you've got the time. So this is onset of illness, and this is in days. So 1, 2, 3, 4, 5 days, 10 days, 15 days, 20 days, etc. So you've got time on the x-axis and on the y-axis, you've got the number of cases. And this here is a point source outbreak. And when looking at an epidemic curve, always think, well, what does the shape look like? So here, you've got one case here on day 11 by the looks of it, but then you've got the vast majority of cases in one kind of spike here. You've got 3 cases a little bit later on, and then you've got no further cases here. So this is a nice, sharp, almost normal distribution peak. And this is a point source outbreak. This is actually a cryptosporidium outbreak. And there's more information on this link here. And what in a nursery, and what's probably happened here is that we've got the index case who became unwell on day 11. The incubation period is usually about 2 to 3 days, but it can be longer than that. So a few days later, after our index case, we start to see the increase in number of cases there, and then it tails off and it goes away. So it's a point source. One thing happened that led to all these other cases. This one, in contrast, is quite different. So that shape is one spike. This shape, it's a lot flatter. There's probably a little bit of a spike there, but it's certainly not coming up to a noticeable spike and then trailing off like this one is. And this is a continuous source outbreak. So we've got the onset of illness. So this is days now, and it goes from the 15th of December up until January. And this is actually an outbreak of salmonella associated with salami. So people were eating the salami throughout, they were being continuously exposed, and they were becoming ill over a longer period of time. It wasn't being spread from person to person, and it wasn't a single point source like we see here. And then the final epi curve that I'm going to show you. And again, you can probably see immediately the difference in shape. So what we can see here is it's all nice and flat, and then we get a spike, and then we get another spike, which is bigger a few days later, and then we get a third spike, which is even bigger a few days later, and then it trails off. And this is a propagated outbreak. So this is an outbreak of an infection that's spreading from person to person. And what's happening here is these people here are ill, and then they're all spreading it to these people here, and then they're all spreading it to these people here. And this is actually an outbreak of measles. And it's classic in that you've got these peaks, and each one is progressively taller. So outbreak epicurves are really useful. You can see just by the shape of the curve a lot about what's going on with that outbreak. So place, we need to know where our outbreak is happening. Outbreaks can happen anywhere, but the location of the outbreak is crucial, and it determines how you manage it. Now, some locations are quite closed. So here we've got a cruise ship, here we've got a prison. These are closed environments. On a ship, you've got staff, you've got travellers, holiday makers. They're all on that ship. They don't really leave it apart from when they're at port and they go exploring. They're all under one roof in close confinement together. It's the same in a prison. Obviously, the staff go home at the end of their shift, but the inmates are again under one roof in close proximity together. So these are closed environments. Schools and care homes and hospitals, we also would consider closed environments. Although obviously with a hospital and a care home, the staff go home at the end of the day, but the residents and the patients don't, they're all together. And of course, with a hospital and a care home, you've got very vulnerable patients and very vulnerable residents in that setting. School, the children and the teachers go home at the end of the day, but it's still closed. Getting a bit more open now are workplaces, whether it's an office or a factory. Again, you've got a large group of people, probably in close confinement for an 8-hour shift or a 12-hour shift, all together under one roof. And then when we're getting into things like faith settings or restaurants or bars, they're much more open settings in that people tend to come and go. People are together for a period of time, but it's usually not 8 hours or 12 hours as we are in a school or a workplace. And then completely open settings would be things like, you know, Sandwell, the wider environment that we all live and work in. Closed settings, it's much easier to identify an outbreak on a cruise ship than it is perhaps in Sandwell. You've got a group of people all together. If sickness and diarrhea is going around that ship, it's really obvious that there's something going on. So they can be easier to identify the outbreaks, and it's potentially easier to contain it because everybody's on that ship and they ain't going anywhere. But you've got very vulnerable people who can't go anywhere, they're trapped. It's the same in a hospital or a care home. The residents and the patients can't escape that outbreak, that they are there, it's happening around them. Whereas if we had an outbreak in a workplace or in a faith setting, actually it might be harder to detect in the first place, but what we don't have is a group of people who are trapped in that setting as they are in a hospital or a care home. So there are advantages and disadvantages to the types of settings, but we need to have an understanding of the place where this is happening, what's going on. And then the final stage of our rapid structured investigation is person. So who is ill? So we need to know a little bit about our cases. How old are they? Is it the very young? Is it the very old? What's their gender? Is it evenly split, or more men affected than women, or vice versa? Ethnicity, occupation, hobbies. You know, the more we know about the cases, the more we can describe the cases, the more we can form a hypothesis of what's going on and what's causing this outbreak. And remember, at this stage, we will not have all the information. With an outbreak, it's always insufficient information. You're always trying to play catch up. So, control measures. Any questions so far from anyone?
Nothing on the chat.
Fab. So we've got our early detection. We've done we've started to do our rapid structured investigation. We now need to introduce control measures. And as I say, we won't have the whole picture at this point, and we can't wait to get the whole picture before we introduce the control measures, because the whole point of control measures is we're trying to stop people from becoming unwell. So we can't wait. We can't do a cohort study and wait for the results to come back and then say, aha, it was the wedding cake that did it. It'll be far too late. By that point, people will have been ill and people may have died. So we're having to introduce our control measures before we know all the facts and before we really understand what's going on. So I've kind of spoken earlier about control measures depend on the mode of disease transmission. Now, we might not know a causative organism. At the moment, if somebody reported a possible outbreak where people had a new cough and a fever, we could be fairly confident it's COVID-19, but we wouldn't know that for sure early on. So our control measures depend on the mode of transmission. So if we're thinking it's something that's respiratory, we're going to be looking at contact, we're going to be looking at droplets. If we think we've got an outbreak of something like Salmonella or E. coli, we're going to be looking at contact, but also at the fecal oral route and food. If we think we've got an outbreak of Legionnaire's disease, we're going to be looking at the water supply, the air conditioning, that sort of thing. So we don't wait for our microbiology, we start looking at the control measures straight away. And again, I've shown you this quite a few times. The most effective control measures are getting rid of the hazard. So if we think that a restaurant is making people ill through the chicken, we're going to stop them selling the chicken, or we're going to close the restaurant. If we think we've got an outbreak of COVID-19 in a workplace because people are coming in while they're ill, we're going to physically remove the people. The people who are ill are not going to be coming in. So it's better to remove the hazard, replace the hazard if you can, isolate people from the hazard. PPE is obviously the least effective of all the control measures that we have. But really, we're looking at control measures based on what we think might be causing this infection, this outbreak. We're going to call an IMT. An IMT is an incident management team meeting, and basically you get together a group of people, a group of experts, in order to manage the outbreak, to introduce the control measures, to investigate it, and to get it under control. And the two goals really of any IMT are to find out what's causing it and to stop it from happening, to make it safe. Those are always the fundamental goals. And these are just a suggested list of people who you might have at an IMT, but membership very much depends on the type of an outbreak. So, for example, if you have got an outbreak of Legionnaire's disease, you would definitely want somebody from the water company there, but you wouldn't want somebody from the water company if it was an outbreak of Salmonella or an outbreak of COVID. Definitely want an infection control nurse if it's an outbreak in a care home or a hospital. You might not want an infection control nurse if an outbreak associated with the restaurant. So really it depends on where the setting is, it depends on the place, it depends on our hypothesis, it depends on what we think is going on. And then the final stage in how to control an outbreak is the evaluation and the lessons learned stage. And this is the bit that often gets missed. That was true anyway. It's probably even more true now, as we're all so ridiculously busy and we're just lurching from one crisis to the next. But really, after any outbreak, we need to be reflecting what went well, what didn't go well, what would we do differently next time, what have we learned? And that might involve publishing, that might just involve, you know, sharing with colleagues or updating a policy. But it's a very important stage, and it is probably the stage that gets missed more often, which is a shame. So we're going to go on to a couple of examples about how this works in real life. And as I say, one is going to be COVID, one is going to be something else entirely by means of a contrast. So, COVID outbreak, unsurprisingly. So you are in charge for health protection. The buck stops with you, you're in charge, and it's Tuesday and it's 11 o'clock in the morning. And an email notification comes in to the public health COVID inbox saying that there are 2 new symptomatic cases in a care home. And one of the information officers phones up the home to get some more information and confirms that yes, that's true, and there's also a staff member who's tested positive. So we want to detect it. Well, that's our early detection. We picked up that email. And of course, early detection depends on us picking up on that email. If we'd have missed it, we might have missed that outbreak in its entirety. So we've picked up the email, we've detected the outbreak quite quickly. We now want to investigate, control measures, and hopefully evaluate. So what do you want to know? What kind of information, further information, do you need to know? Either shout out or type in the type box. Do you need to know anything else?
You want to know the day of index cases and subsequent cases, and those the format that we have for care homes.
Yeah, so you'd want to know a lot more information. So you'd want to know the dates. So when did the symptoms start? Definitely. Anything else?
I've got a question from Mary, Valerie. So
Yeah.
Has there been learning from previous outbreaks that has now become standard practice for outbreak control, or still not enough evaluation?
Sorry, say that again.
Sorry, so has there been learning from previous outbreaks that has now become standard practice for outbreak control, or still not enough evaluation?
Yes, the answer to that. So, I mean, generally that's absolutely true. And, you know, in the UK, we've got the really good setup with the IMTs, which has resulted in a lot of learning from a lot of different outbreaks. And just one example of that, so staff in Public Health England use a system called HP Zone, and HP Zone will flag up if different health protection units are all getting cases of the same disease, and it will link them together. And that goes back to an outbreak of E. coli 0157 in Godstone Farm many years ago. And actually that outbreak was detected, but it wasn't detected soon enough. And the reason being, lots of kids were going to the farm and petting the animals and becoming unwell, and then they were going home and becoming ill with E. coli. And they were being notified to their own individual health protection team, but it wasn't being, dots weren't being joined at a more national level. So that's, and now there's a system in place to prevent that happening. And again, the same is true with COVID. We know, you know, so much more now than we did back in February and March about COVID. And, you know, and I guess one of the lessons that we learned is that we need more staff who've got health protection knowledge and training, which is why you're all listening to me now. So yes, we've learned a huge amount. That doesn't mean to say that we don't have more to learn. We obviously do. And the more we learn about this disease, the more we can tailor our response. But yes, we have. So with a rapid and structured investigation, we need numerator and denominator information. So how many staff are affected and how many staff work at the home, how many residents are affected, how many residents live in the home. We want to know a lot about the home. Who, you know, what type of home is it? Is it a a residential home? Is it a nursing home where people tend to be more dependent and sicker? Is it a home for people who are older? Is it a home for people who are younger or may have learning disabilities? So we need to know a lot about that. Has anybody been admitted to hospital? Has anybody died? Any suspected cases? When was it last tested? There's an awful lot of information that we need to know. And of course, what we get told, first of all, might not be the true picture. And we're trying to manage these outbreaks remotely, and that's always challenging because what you get told might not be correct. So control measures, what control measures are you going to introduce?
Close the home for admissions and discharge from other homes. That would be key. Social distancing and everything else.
Yeah, so it's the things that you already know. So contact tracing is much easier in a closed setting. It's much harder in an open setting because there's more people coming and going, but in a closed setting it's a lot easier. So in a care home we know who our residents are and we know who the staff are. So we're going to do that. Social distancing is important. So normally the advice about isolation is you isolate if you have symptoms for 10 days or if you're a contact for 14 days. But in care homes, we say people, residents of care homes isolate for 14 days because there's evidence that people who are older and frailer tend to be infectious for longer. And then things like hand hygiene, respiratory hygiene are absolutely crucial. It's a care home, so we need to make sure that staff are wearing PPE appropriately and correctly. And yeah, you're going to want to close the home. And the whole point of closing the home is it's not going to do anything at all to protect the people already in the home. They've already been exposed. Social distancing might protect them, but by closing the care home, you're not bringing any new people in. So we've got a closed environment where we've got onward disease transmission. We want to close the home to prevent introducing new vulnerable people who become unwell. And we're obviously going to want to test as well. But of course, we don't wait for the results before we introduce our control measures. We assume it's COVID and we take the response accordingly. So we heard about this at 11 o'clock on Tuesday. It's now 3 o'clock on Tuesday and we're holding an IMT. So this is the kind of timescales involved with outbreaks. It's not the next day, it's not the following week, it is 4 hours later. And really the people we want at our IMT are obviously Public Health England. We want the Director of Public Health or more likely a representative. We may want microbiology, we may want an infection control nurse, we almost certainly do want an infection control nurse. We want people from intelligence, we want the care home manager there. They know their home, we don't, that we need that knowledge and intel. We might want somebody from adult social care, we might want a GP, we probably don't want a virologist, given how stretched thinly they are. But we would hold an IMT where we would plan and we would ensure that the control measures are in place and decide if any further action needs to be taken. It's quite challenging. Outbreak management is challenging at the best of times. It's even more challenging at the moment with the way that we're working. So we're doing all of this remotely. And of course, if I phone up anywhere, whether it's a care home, a restaurant, a workplace or a faith sector and say, are you doing what you should be doing? Of course, they're going to say, yes, Valerie, I am. People don't tend to admit that they're not doing best practice. So you can't be naive and work in health protection. You have to always take things with a pinch of salt. We know, and this is borne out nationally, but also locally as well, that agency staff presented a bit of a challenge. So some staff members were going from care home to care home to care home. And if they had an asymptomatic infection themselves, they were spreading infection quite quickly throughout the homes. And that was a real problem. And there's been some quite interesting papers around that as well. Cohort nursing. If you've got a few residents in a care home who are all symptomatic, we try and keep them together, but that can be quite challenging. We also try and have the same staff looking after people who are ill and different staff looking after people who don't have symptoms. But again, that was perhaps not well understood at the beginning, and perhaps they didn't always have the staff to do that. There's massive challenges in care homes. Many residents of care homes have dementia, and they don't have capacity and often don't understand what's happening. And it must be absolutely terrifying to be a resident in a care home and suddenly your friends and family have stopped visiting you. They used to visit you, now they have just stopped and you don't know why. All of the staff that you know are now wearing visors and masks and gloves and won't come near you without a visor and a mask on. And some of the people that you've lived with for many years have died or disappeared into hospital and were never heard of since. And it can be very challenging, and it must have been absolutely hellish for many of the residents in care homes who don't understand what's going on and who are wandering around and potentially spreading infection and are probably very, very frightened and confused about what's going on. There were issues with PPE. Care homes did not have adequate PPE at the beginning. That's resolved now. And hopefully, if we do see a second wave, hopefully that will not be an issue again. But certainly I know my colleagues in adult and social care have done a huge amount of work around that. Some of our homes are just challenging. They've got carpets, you know, this is a teddy bear. We had an outbreak once. It wasn't COVID, it was before COVID, and we had an IMT and we discussed the outbreak, and the home told us, oh yes, we're very clean, everything is done correctly, we've thoroughly deep cleaned the entire home, it's absolutely spotless. And Linda and Claire went round there to have a look, and they found it was dirty, it was grubby. There was a communal teddy bear that residents passed from person to person that was really dirty and grubby and ripped and damaged. And so often you have to go and see what's going on, but given that we're all working remotely at the moment and given how incredibly busy we all are, that's not always possible. So there are some real common issues. So with care homes, you follow up with regular phone calls. Ideally, we go out and visit. That's not necessarily possible at the moment. We keep testing people, and we would close an outbreak of COVID-19 28 days after the last case. So that's 2 incubation periods. And I guess we have, you know, so Mary's question earlier, we've learned a massive amount since the beginning. We now have a rota system. We have information officers who are phoning the homes on a daily basis to get the data gathering, and that's another way of potentially the early detection of an outbreak. So the IO's role is absolutely crucial. We've got 2 infection control nurses, both of who are brilliant, but both of who are part-time. So we're training up other people as well to help support this health protection function. So we're trying to get on the front foot. We're trying to be a bit more proactive about it all than we were certainly back in March when we were just firefighting. And I've shown you this before. This is our award-winning Sandwell outbreak plan written by Paul and Lisa, and there's a lot of information in there. So, although with my COVID outbreak I've touched on care homes, and the reason I did that was quite deliberate because care home residents are incredibly vulnerable. We are seeing outbreaks in other settings, and I'm sure you've all seen in the press that we have got several outbreaks at the moment in places of work. We have had an outbreak in a school, not now because the schools are closed, but we can expect to see outbreaks in school from September onwards when they do reopen. And the other settings, there are pros and cons. So with a school, the children are usually healthy. The staff, not always, but generally are, because it's a healthy workforce. It's a semi-closed environment. You do have people together for prolonged periods of time, but they do go home at the end of the day. But children aren't the best respecters of social distancing, so young kids just dribble over everything. Older teenagers, you know, they kiss and canoodle and they do their old thing. So schools, although children aren't particularly badly affected by COVID, it's interesting to know what the role of schools is in wider spread. And I think there was a paper referred to the other day by the health secretary or by the education secretary that suggested schools aren't implicated in further spread, but I'd certainly like to read that and see the detail behind that. And then workplaces. Again, not always, but you've generally got a reasonably healthy staff, that they're well enough to go to work. They're not going to be as old and frail and have the same comorbidities as care home residents, for example. But it's semi-closed, you've got people together for a long period of time. And there might be issues. Some employers are better than others. If you're a member of staff who you're on a 0-hour contract, and you've got 3 children to feed and you won't get paid if you don't go into work, it's very difficult to manage that, and there have been some challenges in many of our outbreaks in workplaces. And certainly the Sandwell spike that we're seeing, we think behind that we think is our workplaces. So I'm now going to move on to something completely different, because this is a non-COVID outbreak, and it's also managed in a slightly different way in that we did analytical epidemiology. And again, I'm quite conscious that we're obviously focusing on COVID because of what's going on, but there is far more to health protection than this. And the general principles of any outbreak can apply in any setting and any organism. This is a true outbreak that I was involved with myself a few years ago, and it was Wednesday, it was 2 o'clock, and again, you are in charge of health protection, so the buck stops with you. And a member of the public either phones or emails to report food poisoning. Him and his son have both become unwell, and both have eaten at a local kebab takeaway. And then, a little bit later, you start getting reports through into the inbox of about 20 cases of diarrhea and vomiting, and at least one of those cases has been hospitalised. So Wednesday, it's the same day. We got the first report at 2 o'clock. This is true, by the way. This is the actual timescale of how it happened. The first case reports came in at 2 o'clock in the afternoon. At 4:30, we declared an outbreak, and we started the investigation. And at 6:30 in the evening, the takeaway voluntarily closed. It's probably worth saying that this is one that I was involved with when I worked in London. It's nowhere near Sandwell, in case anybody is wondering. So again, I'm illustrating this to show you how quickly we have to move. Really, within 4.5 hours of the first report coming through, that takeaway had closed. You don't have time to hang around. This isn't something that can wait until the next day. Action is required immediately. We held an IMT, and the IMT was to try and introduce control measures to prevent any further cases and identify any possible food sources. So our hypothesis was it was an outbreak of food poisoning associated with the kebab takeaway. So what control measures are you going to introduce here? So it's quite a different outbreak. What control measures do you think are required?
Close the kebab shop for a start.
Absolutely. That is the most important, and they already did it. They did it at 6:30, but the most important control measure is closing that kebab shop, because if that is the source of the outbreak, it can't carry on selling kebabs or selling the food to the public. So the closure is the most important. Now, we were fortunate in this case in that they did it voluntarily. Environmental health officers do have legal powers to close premises, but that delays matters and is not a simple process. So it's always better to get the cooperation of the premises involved. Any other control measures? What else are we going to do?
You might want to check the staff from that shop if they've got diarrhea and vomiting and whether they need to stay at home.
Yeah,
well,
exactly.
The shop's closed, but they would be.
Yeah. So exactly what's going on with the staff, definitely.
You want to investigate everything else in the shop, the sources of the meat. Maybe there's bigger outbreak if you don't. I'm thinking of the meat or the other stuff that they use in the place.
Yeah. So it could be something that's local to the kebab takeaway, or it could be something bigger. It could be that the meat that they get from a national source is contaminated, and actually it's something that we're seeing across the region or across the UK. So definitely. So the most important control measure is you close the takeaway. That's crucial. That if it is that kebab takeaway that's causing the problems, we've closed it. We've prevented any further cases straight away. Environmental health officers visited and they reviewed the premises, and I'm going to show you some photos in a second. We got some microbiological samples, and we got samples from the cases. So we got stool samples from the cases, but we also got food samples from the kebab takeaway and also environmental samples from the kebab takeaway. And what we were hoping was to get a link between the stool specimen from the people who were ill and the premises. So food was confiscated by the EHOs. It was taken to the Food, Water and Environment Lab, maintaining a chain of custody. Staff were given education. None of them were actually symptomatic. None of them were ill themselves. And the premises were thoroughly cleaned and disinfected after, obviously, the samples had been taken. So some photos were taken. And as I said, this is in London, so it's nowhere near here. So don't worry if you had a kebab over the weekend. But this is the kitchen in the takeaway. And you can see here, this is the grill. It's completely thick with grease and dirt. There's not very much room really at all. The kind of cooking instruments are quite grubby. It's all very dirty and greasy here. This here is also the kitchen from the other point of view. And again, it's a typical London premise in that you don't have room to swing a cat. There is no room in there at all. It's very cramped. This is the bin. There's no lid on that bin, so that's completely open to the air. That's the tea towel. I think I've said to you guys before, the dirtiest thing in any kitchen will be the tea towel, and that's absolutely filthy. You can just tell by looking at it. That's the sink. You can't see it, but in the bottom of this sink is raw frozen chicken that is defrosting in water at the bottom of the sink. We've got no separation of food prep at all, so that the chicken is being prepped on the same surfaces as the tomatoes. This door here, behind that door is the toilet, the staff toilet, and there is no soap in that toilet. So even if the staff members wanted to wash their hands after using the toilet, they can't. There's no soap in there. So it's all a bit unacceptable, really. Although EHOs who are on this call will think, well, I've seen a lot worse, and you almost certainly will have done. This here, as well as being a kebab takeaway, they sold whole rotisserie chicken. So people could come along, they could buy a chicken, they could take it home, and that would be their dinner later that day or the next day. So it wasn't just kebabs. And the whole chickens would be on the spit, and the spit would turn round and the chicken would cook, and then people would buy the chicken and take them home. The problem was that the takeaway were putting the raw chickens on the top and were serving the public from the bottom. So the raw chicken was dripping down onto the cooked chicken and was contaminating, and people would have been buying contaminated chicken. So again, no understanding about basic food hygiene there. It should have been the raw at the bottom, the cooked at the top, and they were doing it the wrong way around. So it really wasn't a great picture. So as I say, we got samples from the cases, we took stool samples, we got food samples, and we got environmental samples. And unlike before, so with our COVID outbreaks, virtually all of our COVID outbreaks, we're just doing very basic descriptive epidemiology. So we talk about the time, place, person. We say that in a workplace where 70 people work, 20 people are unwell. That's kind of the level we do. In this case, we wanted to go a little bit further, and we wanted to do some analytical epidemiology. And we actually did a cohort study, and all the cases filled in a food questionnaire. And if you've ever done one of these, you get the menu from the premise. So you get every single item that's for sale on the menu. and then you will phone up all the cases and say, what did you have to eat? And you go through each menu. So you say, did you have the tomato? Did you have the cucumber? Did you have the lettuce? Did you have the onion? You don't just say, did you have the salad? Because people might forget what they ate. And by salad, well, they might have had the tomato, but not the radish. So it's quite laborious. You have to go through literally every single item that is for sale, one by one. Did you have it? Yes, no. So this is what we did for our analytical epidemiology.
Valerie, sorry, can I just interrupt there? Linda just wanted to ask, what was the organism?
I'm coming to that, Linda. Spoilers. So people were very ill. This wasn't a mild self-limiting illness. There were 66 cases in total. All of them had diarrhea. Most of them had abdo pain. Most of them had fever. Most of them had a headache. Most of them vomited, and some of them had blood in their stools. And actually, of the 66 cases, 22 were admitted to hospital. So that's a massive, that people were very unwell with this. And of the people who were admitted to hospital, the median length of stay was 4 days. So they weren't even admitted overnight. They you know, people were seriously unwell. Fortunately, there weren't any deaths, but there were some very sick people as a result of this outbreak. And this is our epidemic curve. So we can see here, it comes to a bit of a spike and then it tails off. What does that tell us?
Source, maybe?
Yeah, this is a point source outbreak. So this isn't continuous, this isn't spread person to person, but something has happened, and we don't know what yet, but something has happened over here, and then as a result we've seen an increase in cases, and then it's tailed off there. Oops. And just bear with me a moment, my PowerPoint is having a bit of a, it's just, sorry about this, guys, my PowerPoint is just having a, that's better. So yeah, point source outbreak. Something happened, we don't quite know what. So sorry guys, I'm just restarting the PowerPoint as it crashed. See the presentation again?
Not yet, Valerie.
Right.
Okay, see it now, Valerie.
Brilliant. So sorry about this. Right, let's go back to where we were. So yeah, this was a point source outbreak. So something happened, we don't quite know what, and we got a spike in cases. So Linda asked what the causative organism was. It was Salmonella enteritidis phage type 14b, and we found this strain of Salmonella in the in 7 of our cases, so in the stool samples from 7 of the cases. We also found the same outbreak strain from a swab taken from the floor of the fridge, from the light switch in the staff toilet, and also from leftover chicken from a case. So somebody had bought a chicken, had taken it home and put it in their fridge to eat the next day. We got that chicken back off them and we found that our Salmonella in there. Unfortunately, there's no chain of custody there because we don't know what happened to that chicken after it left the premises. Of the food samples that the environmental health officers took, none of them, we didn't find any of them, none of those tested positive for our outbreak strain. So it was Salmonella enteritidis. This is the results of our cohort study, and it's not exactly helpful. So this isn't everything on the menu, it's just the top few. You know, we got a bit of an odds ratio as to what might cause illness. It could have been the rotisserie chicken. You know, the odds of being ill were 2.75, greater if you'd eaten the chicken than if you hadn't, but you know, it's not certain. So we really don't know what of the food items caused this. And for those of you who understand, you'll see that certainly some of these items have got absolutely massive confidence intervals. You know, we had a lot of uncertainty. So basically, there's no smoking gun here. We can't say it was the rotisserie chicken, it was the chips, it was the naan bread. We just don't know, although these things are possibly implicated. We use the media. We often think about the media as the baddies. We prepare reactive statements, but we don't want them to know about it. But actually, we went out to the media quite deliberately because we were worried that people had bought chicken, had them in their fridges at home and hadn't yet eaten it. So we basically went to the press and said, if you have bought a chicken, or if you bought any food from this kebab takeaway, don't eat it. And contact us, and that's how we got hold of that chicken. So actually the media can be a very useful tool in outbreak management. And this one was actually written up by a colleague who I worked with at the time, actually till receipts were used to estimate the cohorts. It was quite an innovative piece of work. So the references in the slides for anybody who's interested in reading a little bit more about it. So that's two outbreaks there, two quite different outbreaks, different organisms, and they were investigated in different ways. But there are some general themes and general trends. And the first one is time is absolutely crucial. We don't have the luxury of time. The sooner we act with an outbreak, the sooner we can prevent further cases, and the sooner we can potentially stop people becoming unwell or potentially dying. The other theme is insufficient information. We will never have enough information at the start. And normally with a project, you would wait until you had all the information and then you might take action. And you can't do that with an outbreak. It's a case of we've got to act and we've got to act immediately. Often the information you get is inaccurate. You know, some of the notifications we get in through our care homes, well, I remember one very scary day, it said there'd been 6 deaths in a care home, and we phoned that care home thinking, oh my goodness, what on earth has happened? And that wasn't the case at all. It was somebody had incorrectly filled in the form. So what you hear about at the beginning might not be accurate and often isn't. Outbreaks are rapidly changing. They are uncertain and they are fast moving. A lot of the time you have to rely on goodwill. So I work in health protection. I don't have any regulatory powers. I can't close anywhere down. I have colleagues in environmental health who can, but you know, it's always better to rely on the goodwill. So it's far better that a takeaway or a care home or workplace close voluntarily than we have to go down the legal route. It's a lot quicker, it's a lot easier, it's a lot less hassle. And also publicity. Publicity can sometimes be really helpful in managing and controlling outbreaks. And then, just to conclude, to manage an outbreak, we need to detect them early, we need to rapidly and structured investigate, we need to introduce control measures, and all of this is happening at the same time. We don't wait for our investigation before we introduce our control measures. We do all of it at once, and then we evaluate it at the end. And we are really working against the clock with these outbreaks. So thank you all very much. Any further questions?
There's nothing on the chat, Valerie.
Brilliant. Okay, so I guess that's it. So I guess, Joe, thank you. We can stop the recording now. So lovely. Thank you very much for everyone for dialing in.